Hello, dear friends, dear colleagues. My lecture is on awareness into an unrecognized entity, and the subtitle is Transalveolar Ultrasonography versus Radiography in the Assessment of Bone Marrow Cavitations and Successful Jawbone Detox. What we mostly all know is what are jawbone cavitations. Jawbone cavitations are here wonderful in this upper slide to see black holes inside the jawbone. And this is a picture of my friend Professor Jerry Bucco. And the question is, what is inside these black holes? Is it air? Is it liquid? No. The picture below shows you it's fat. So these cavitations are filled with fatty, degenerated adipocytes with fatty, degenerated osteonecrosis of jawbone. And this is why we call this phenomenon FDOJ. Only in cases of facial pain or trigeminal neuralgia, we call this phenomenon NICO, because then it's neuralgia-inducing cavitational osteonecrosis, and this term was created by my friend Professor Bucco. What happens when we take these fatty lumps and send them to a modern lab for the so-called multiplex analysis for cytokine expression? And here, this picture shows you the medium value of this cytokine expression from in 128 of these FDOJ samples. And these 128 FDOJ samples, all we got post-surgery from patients with chronic immune diseases. And here you see the pattern of 7 of these cytokines. And it's amazing that just one cytokine, it's the chemokine rantis, is highly overexpressed, much higher than all the other cytokines. It's interesting to see that our famous TNF-alpha is lower in these fatty degenerated areas than in healthy jawbone. Healthy jawbone is the blue columns, and FDOJ is rantis in the red columns. And so you see the huge difference, and you see that rantis is about 35-fold overexpressed in these FDOJ areas than in healthy jawbone. This is the story I want to tell you, and the story is the data review of 5 years assessment of 1,472 patients with chronic immune diseases. It's a data review of rantis-based immune dentistry of these 1,472 really sick patients. Chronic illnesses like cancer, heart disease, neurodegeneration, gastrointestinal issues, and autoimmune conditions are on the rise in unprecedented numbers. How is this even possible? What are we missing? And now here you see in 5 years from 2017 to 22, we have these 1,472 patients, and they all were here controlled with rantis diagnosis and with rantis therapy in our clinic for integrative medicine in Munich. And we have about 7 groups of patients here, patients with allergies, with chronic fatigue syndrome, with neurodegeneration like ALS or MS. We have a rheumatic group, we have a trigeminal group, and we have about 5% of these patients with tumors, and we have parasympathetic deregulation like heart arrhythmia, blood pressure problems, and so on. Why would we like to call this a rantis-based immune dentistry? The answer is, rantis This is the abbreviation, regulated on activation, normal T cell expressed and secreted, and focus on T cell expressed. You know, T cells. T cells are the most important part of our immune system. Second, Rantis is a selective chemoattractant for T cells, eosinophils and basophils, and so Rantis plays an important role in recruiting leukocytes into inflammatory sites. What we did is we normally do a pre-surgery screening of our chronic immune diseased patients for Rantis in serum. And this is the outcome. The normal level of Rantis in serum is about 29 nanograms per milliliter on the very left. We did these on 1,426 of these patients, and the outcome is that above the threshold of 29.6 nanograms per milliliter of Rantis in serum are 1,137 patients of our collective of chronic immune diseased patients. This is about 80% of these patients have primarily more Rantis in serum as they should have. The median value is 51.7 nanograms per milliliter. This is a very interesting item, that Rantis is an important issue in all chronic immune diseases. The next question is, finding Rantis high in serum opens up two questions. Is the origin of this inflammatory Rantis signaling in the jawbone? And second, how to detect Rantis sources and cavitations in jawbone? The answer is measuring bone density, checking for cavitations, measuring bone density through 10-trans alveolar ultrasonography. The abbreviation is TAU. And this is what our new TAU device will show you. On the left, you see a wonderful X-ray, and you see a wonderful edentulous area in a left lower jawbone, and you can't identify any suspicious processes inside the jawbone. But below the X-ray, you see a green spot, you can see a green focus, which corresponds to the last molar. But rear to the molar, we see red spots. And red in this machine means we have a low bone density. Green means we have a solid bone. And on the right-hand slide, you see the screen of this TAU device. How does it look like in praxis? You have on the outside, you have a sender, and the inside, anorally, you have a receptor. And the sender from the outside is sending the ultra waves through the cheek, through the bone, and the receptor has about 96 piezoelectric sensitive areas, and they measure the attenuation of the sound going through solid substance, which is better, and the attenuation is higher for the ultrasound going through liquid or fatty tissue. And with the next picture, I show you a clinical case. And the left slide again, totally inconspicuous X-ray, but you see the red spots in the TAU machine. Next slide, you see how deeply the fatty degenerated area goes down to the infraalveolar nerve, and on the right hand you see the scraped out sample of fat we send to the lab for the Rantis diagnosis. And in case nobody would do the surgery on the left slide due to the X-ray, we did this surgery due to the red spots on our TAU device. And you can see how reliable it is in the clinical outcome at the end. This is the results of post-surgery of 1,421 patients, post-surgery FDOJ analysis for Rantis expression. Again, on the left, we have the normal level of Rantis in healthy jawbone, and this is about 150 picograms per milliliter, only picograms. We did this analysis in 1,421 patients, and only 5 patients of these 1,421 had in their FDOJ analysis a Rantis expression below 150 picograms per milliliter. This is only 0.35% of our FDOJ surgeries had the normal or below Rantis expression. 1,416 of this group, of these all patients with chronic immune diseases, had a medium level of 2,207 picograms per milliliter. That means they had in their jawbone a consistent Rantis overexpression 14.7-fold higher than normal. Did you know that cancer, diabetes, heart disease, strokes are all inflammation-based illnesses, and what literature can show us, most likely Rantis-based? So when we do a search for literature in Medline or in PubMed, here we get, in case we type in Rantis and allergy, we get the results of 1,055 articles. If we type in Rantis and neurodegenerative disorders, we get 116 articles. If we type in Rantis and rheumatism, we get also 167 articles. And Rantis and tumors gives us this wonderful result of 743 articles. That means 743 medical researchers tried to find out where is the connection of Rantis, of tumors and Rantis expression. And this is here gives us the idea to check in these 1,472 CID patients with our TAU, with our ultrasonography, to check for these FDOJ cavitations. And this is what we did with this TAU device in our clinic up to now. We checked these 1,472 patients. We checked them with more than 53,000 TAU scans for jawbone cavitations. And the outcome is, as we of course check each odonton with 3 scans, as we scan healthy jawbone before and healthy jawbone behind a jawbone area, suspicious jawbone area, we got per CID patient, we got more than 73 scans. That means in the outcome that each of these 1,472 patients detected 3 FDOJ cavitations in this TAU machine. What is the result? The result is 3 jawbone areas with diminished bone density we detect per in each single CAD patient. The result is 3 jawbone areas in each of these patients has a Rantis overexpression. So in our cohort of 1,472 CAD patients, Rantis is the biomarker of local, in jawbone, and possible systemic silent inflammation. The conclusion is Rantis in jawbone cavitations is obviously epidemic in patients with CID. Going away from statistics, back to clinical results. And here I show you a case with this lady had neurodermatitis for 6 years. The therapy for her was mostly cortisone. And you see her arms, you see her face, and here you see her X-ray, her dental X-ray here. And below the X-ray, you see the outprint of the TAU check for FDOJ inflammations in jawbone. And I want to focus on this left lower jawbone area, on this, just on this titanium implant, and on the outprint below the X-ray, you see in this area, we call it number 36 in Europe, in the European terminology, you see these red spots. And these red spots, you see the magnification on the right side. We see on the upper right side, we see the 2-dimensional display on the TAU device of this diminished bone density. And you see the red spots, you see the bone, the inflammation, the chronic inflammation in the jawbone, just around the green implant. Of course, implant is hard is green, and just below you can see this display in a 3-dimensional projection. White is the implant, around the implant, precisely adjacent at the implant, you see this chronic inflammation. Left side shows you the titanium implant we took out and shows you this wonderful, this impressive fatty degeneration directly adjacent at the implant. And this is FDOJ. And in case we scrape off this fatty degeneration, we send it to the lab for multiplex analysis. The outcome is 6,174 picograms per milliliter of Rantis exactly in this area, deriving from this area, chronic Rantis input from this area, in contrast to 149 picograms in healthy jawbone. This is about a more than 50-fold overexpression of Rantis. Chronically, without pain for the patient, but chronic Rantis input. For instance, on the right lower jawbone, we also find below the X-ray, you see these red spots here in these bone areas. And on the left side, you see again the magnification in 2 dimensions and in 3 dimensions. Again, a great hint, a great demonstration of chronic inflammation in jawbone. And the next picture shows you here how a surgery in this left lower area looks like. And in 3 of these retromolar areas together in this patient, we have a Rantis overexpression of 2,000. This is about more than 20-fold compared to healthy jawbone, 149 picograms per milliliter. So in this lady, we have a chronic, tremendous overexpressed Rantis input. This is what we did, taking out all these metals, taking out the implants, cleaning out the jawbone areas where we found the FDOJ. And this is the ultrasound, the ultrasonography after 6 months. And what we can see is very precisely in this outprint of the TAU device, we have mostly green. That means we succeeded in diminishing her chronic input from jawbone. This Rantis chronic input, we succeeded to diminish that near to zero. It's nearly gone. And as it is gone, here you can see the difference from her neurodermatitis in the face to the clinical outcome after this Rantis diminishing therapy, including the control with the ultrasound device. Let's go to Google Scholar. Let's see, is science-based medicine, do they know how far Rantis is involved in the epistemology of neurodermatitis? And just taking out two of these 194 outcomes. Here we can see number one is, I'm citing this, there was a significant association between the upregulation variant of Rantis and atopic dermatitis, or number two, these results suggest that Rantis, as well as its receptors, CCR3 and CCR5, may play important roles in the orchestration in originating chronic inflammation in atopic eczema. So why not checking for Rantis expressing jawbone areas with ultrasonography? And if you do this and you diagnose this properly, and in case you make a proper therapy, you have this wonderful outcome of this patient. Now, question, is this a single case, or could our approach to CID be a new immune dentistry through TAU and through jawbone detox of these Rantis overexpressions? And here I show you a short market survey of our patients. The question was, or one of these questions was, I'm under the impression that my health improved significantly due to the FDOJ surgery. And you see 52% and about 30%, nearly 80%, they got a wonderful outcome. They were really happy in eliminating these chronic Rantis surgeries. Second question was, I found the possibility of performing TAU ultrasonography in my jawbone to be very good or just good. And we have an outcome of nearly 90% of these patients. They were so happy to find a new method to detect or to answer the question for chronic inflammation in jawbone, to answer the question, is a chronic Rantis input damaging my overall health? And this is a wonderful result. Back to my subtitle. Transalveolar ultrasonography versus radiography in the assessment of jawbone. And now we concentrate on the jawbone around implants. And the question is, why is TAU superior in the assessment of jawbone around implants to radiography? Example, case number one, patient, chronic facial pain after implant. The history is she got this implant and now for 6 months she has chronic pain in upper right jawbone. Up to date, all treating dentists were helpless. This is the CBCT to clear the question, where does this facial pain come from? And you see the CBT frontal, you see the CBT sagittal, no possibility to evaluate the jawbone quality up there. But below the X-rays, you see the red spots in the CaviTAU device. And on the right hand, you see the magnification of these tau display. And again, you see the green implant and you see the red chronically inflamed bone around the implant. Same on the three-dimensional picture right. What did we do? We took out the implant, we cleaned the bone, and here you have the histology on the left side. And what did the pathologist find? He found an apical granuloma, he found foreign material, and he found fibrous connective tissue. So was the jawbone around the implant healthy? Was the patient just a victim of her feelings? No. The Rantis multiplex analysis also showed 1,587 picograms per liter of Rantis. And this is also a proof, a scientific proof, of this chronic inflammation up there, just shown by the TAU device. Case number 2, also chronic facial pain after implant. This is a ceramic implant also on the right upper. And again, you see the green areas in the TAU, and you see the red spots, you see the display of chronic inflammation distally of this ceramic implant. What did we do? We took it out, we sent the bone we scraped out, the softened bone we scraped out to the pathologist. The outcome is florid inflammation, and he also can see a radicular cyst in this area. And now, amazingly, the outcome of the Rantis analysis is 13,400 picograms per milliliter. This is more than 100-fold overexpressed Rantis input around this wonderful ceramic implant. Next step could be, why is CaviTAU superior in the assessment of jawbone on root fillings and post-endodontic inflammations? Again, X-ray, totally unconspicuous. Again, you see the CaviTAU below, it's red. What does the CBCT show in this area? What should we do? What should we do? Just a question mark, but no clear answer, just in contrast to the TAU device. And this is the outcome here. Here again you see the analysis of 7 cytokines in this post-endodontic inflamed area. And again you see the magnification, it's red in TAU, and the expression of Rantis is again more than 6,000 picograms per milliliter of Rantis expression. A second case, radiography versus TAU image. Again, you see the root filling, it's a bit overpressed. You see the wonderful, here in this area, red spots in this TAU device. What is the outcome? The contrast medium is showing the fatty degenerated area around, below the apex of this root filling. And it shows again 7 cytokines, no TNF-alpha, no interleukin-6, what we would expect. But it's not an acute inflammation. It's a chronic, subtle, subliminal inflammation, not an infection. And the proof that the overall health might be damaged out of this area is the highly overexpressed Rantis with 9,900 picograms per milliliter. Let me come to a conclusion. First, in these jawbone cavitations, we find chronic singular Rantis overexpression. Second, Rantis has a well-known high interface to overall health. This is what literature, what a look to Google Scholar or to PubMed will show us. Third, our data proves an epidemic spread of FDOJ pathologies, at least in our group of 1,472 patients with chronic immune diseases. And fourth, in contrast to the standard X-ray diagnosis, our TAU displays cavitations accessible for successful jawbone detox, as I could show in all these clinical cases. Now we have also valuable information at table clinics. This is a handout on our science-based papers on Rantis overexpression and the scientific validation of our ultrasonography machine. And second, we have a book, Cavitational Osteonecrosis in Jawbone and Ultrasonography CaviTAU in radiation-free imaging on maxillomandibular osteoimmunology, of course in English, 320 patients of valuable, extremely valuable information and great pictures to prove the actual existence of this phenomenon. Thank you very much for your time and for your attention.